Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Welcome to this webinar on considerations for shared decision-making on the use of anti-amyloid therapies in clinical practice. I'm Ron Peterson, Cora Kenau Professor of Alzheimer, Professor of Neurology at the Mayo Clinic in Rochester, Minnesota. I'm going to be joined today by Dr. Ali Atri, who is the Chief Medical Officer at Banner Research and the Banner Alzheimer's and Research Institutes in Phoenix, Arizona. So today what we'd like to discuss is take you through sort of the story of how to use anti-amyloid therapies now that they're out in practice. So we're going to talk about introduction to the amyloid-lowering therapies. We're going to talk about who's eligible for these therapies, and then how do you monitor them? How do you follow up patients who have been treated? So let's start with the therapies themselves. The goals are very important. That is, we need to tell our patients that the goal of these therapies is to preserve cognition, daily function, and quality of life. They provide patients with more time at earlier stages of the disease when individuals are still relatively independent and living in the community. So again, the clinical characterization of these individuals is mild symptomatic Alzheimer's disease. We'll get to this, but we're talking about mild cognitive impairment and mild dementia. So the two drugs we'll be considering today are lecanemab and donanemab, and the indication for both of them is mild cognitive impairment or mild dementia with biomarker confirmed Alzheimer's disease. Lecanemab was approved in the middle of 2023 and donanemab about a year later. So lecanemab is targeting protofibrils and amyloid plaque formation theoretically. Donanemab really is targeting a particular moiety on the amyloid plaque. So it's really meant to reduce plaque. The administration of the two drugs is slightly different. Basically, the difference is lecanemab is once every 2 weeks and donanemab is once every 4 weeks. How long do you treat? Well, both of the trials were 18 months, and with the lecanemab, they recommend that following the 18 months of therapy, you consider maintenance therapy perhaps once a month. Whereas with donanemab, they say if you get a follow-up amyloid PET scan, if the amyloid PET scan is negative, you can stop therapy. So there's a slight difference there in the cessation of the two drugs as recommended. So the basic data with lecanemab were as follows. The clinical impact was a slowing of the rate of progression on the CDR sum of the boxes. So after about 18 months in lecanemab, we see that there was a change of about a half of a point on the clinical dementia rating. On the cognitive scales, the ADAS-Cog14, again, there was about a 1.5 points, and we'll come back to this as to what this may mean. So when we talk to patients, we say, translate that into some practicality for me. So here is the rates of progression on the CDR, the clinical dementia rating, for those who were treated in the first 18 months and those who were on placebo. So at about 18 months, you see a difference there between the black curve and the green curve. So in fact, the lecanemab slowed the rate of progression on this clinical index. The next 18 months, of course, were now in the open label phase. So the individuals who were on placebo were transferred to active drug. So the magenta line there that separates the treated line with the green from the magenta is using controls from ADNI, or the Alzheimer's Disease Neuroimaging Initiative, which is a longitudinal observational study. And these patients were felt to be about the same as those individuals who were in the placebo phase of the clinical trial. Turning to donanemab, we see somewhat similar results. Again, they used a scale called the IDRIS, which is a combination of cognitive function and functional scales. And on the right, they used the CDR sum of the boxes. And they saw about a 0.67 sum of the box change between the two drug treated and the placebo condition, approximately a 35% slowing of the rate of progression. And similarly, if you look at the rates of progression on the CDR global scale, again, the treated group showed a slowing in the rate of progression. And we can see in the left-hand part of this slide that that resulted in a reduction in amyloid level by, say, 18 months, that 76% of people had, in fact, their amyloid levels reduced to virtually normal. Now, there are side effects. There are infusion reactions with both of them, and the infusion reactions are generally mild, generally can be tolerated, can be treated, but they are real, and you need to talk to your patients about them. If you encounter the infusion reaction, you can reduce the infusion or stop the infusion, and you can consider pretreatment to reduce the likelihood of a future encounter of this. So, the other side effects then revolve around the ARIA, the amyloid-related imaging abnormalities. And let me turn to my colleague to discuss these with you. Ali?
Great. Thanks, Ron. Really appreciate it. So, these are our first generation disease modifying drugs because they're affecting, as Ron mentioned, a pathobiology in the course of the disease, removing plaques, lowering plaques. And at the same time, as he showed you, they're showing disease modifying properties in the sense that they're also seem to be slowing down the rate of decline. But of course, that's the efficacy side. What about the burden and the risk side? Well, as monoclonal antibodies, I think infusion reactions are pretty well known in many of the drugs that we use. Those are pretty manageable. They tend to be mild or moderate and not so severe, not to reoccur, and with pre-medication usually tolerated. The major side effect of this class, it's a class effect, is ARIA. ARIA, it stands for amyloid-related imaging abnormalities. And it's really important to appreciate that these are imaging findings. These are not symptoms. And they're observed on MRIs that are done for monitoring and safety purposes. And in the clinical trials that Ron showed in the phase 3 clinical trials, as part of protocol safety monitoring for ARIA, about 3/4 of what was observed on the MRIs did not have any symptoms related to that. And ARIA can be of a few different flavors. One is could be effusion. It could be a little bit of a swelling through leaky blood vessels that are saturated with amyloid. And as the antibody is clearing, there's almost like a traffic jam and inflammation that occurs. Or it could be a blood leakage, hemorrhages or microhemorrhages. And of course, it's important to appreciate the microhemorrhages are also part of the natural evolution of Alzheimer's itself. But typically, these imaging findings are transient and very manageable in clinical trials. We have almost 20 years of experience with them, but those are very rigorous controlled environments where everybody's on the same page, people are proficient reading them, etc. And really our concern has been translated into clinical care. When ARIA is symptomatic, it could be vague. People could have non-specific symptoms like mild headache, a little bit more confusion, a little bit dizziness, sometimes feeling a little bit nauseous, or some symptoms can be almost stroke-like in severe cases. So what we're really trying to prevent and detect are serious ARIA. And we do this by careful patient selection and monitoring. In the clinical trials, we'll go through them a little bit more. The ARIA rates overall were really dependent on ApoE4 characteristics. And serious ARIA was really uncommon. You can see the numbers down there below, somewhere from 1% to 2% or less. But there's management protocols for all these. It's also important to appreciate that after the phase 3 clinical trial for donanemab, there was a modified titration that follows here that I will talk to you about more in the next slide that actually reduced ARIA rates. And what you can appreciate is in donanemab, remember there was a once monthly every 4 weeks. In the phase 3 trials, you had 3 infusions at 700 milligrams, fixed dose every 4 weeks, and then the regular induction dose was 1,400 milligrams thereafter. The modified titration, which has just been published, and actually there is updated prescription information to donanemab for this, basically halved the first dose. So instead of giving 700, you see they gave 350. The second dose stayed the same. 4 weeks later, 700, then 1050. Then they went up. And this significantly dropped the ARIA frequency rates, as you can see here on the right side. When you look at overall ARIA, in the phase 3 for lecanemab, donanemab, and also this all six modified titration trial, one of the things that you'll notice is that it's really dependent on ApoE4 carriage. So you can see on the second row there, no matter what drug you're using, ApoE4 non-carriers on average have lower rates, anywhere from 5 to 16 to 12% in the clinical trials. But as you have more ApoE4 alleles, if you're heterozygous, that number is almost doubled in some cases. For example, in lecanemab, and in homozygous, it's even higher than that. But of course, with this modified titration for donanemab, the numbers have dropped. Again, symptomatic ARIA, very low. Of those folks, as I mentioned, about only 25% have any sort of symptoms, and usually they're mild or transient. And ARIA-H, as you can see, can be upwards of 17, 30, 20%, depending on the trial. But the background rate for patients on placebo for ARIA-H rates are about 8 to 10% in these trials anyhow. So that's really the major side effect that we're trying to monitor and control for. I'm going to turn it back to Ron again here.
Okay, thanks, Ali. So who's eligible? What's the intake here? And I think this funnel is pretty informative. So at the top of the funnel, again, we're talking about people who meet the clinical diagnostic syndrome of either mild cognitive impairment or mild dementia. So that's a rather tight window. Then we have to verify that, in fact, they have amyloid as a possible contributor to their condition. So evidence of amyloid pathology. They have to be able to tolerate multiple MRIs. So as Ali said, for safety purposes, there are regular MRIs scheduled to make sure that we're not getting increasing amount of ARIA under the treatment. And then, of course, we have to be concerned about cerebral amyloid angiopathy because that can drastically increase the risk of having side effects. So those are the standard factors. Now, there are others that may be somewhat health system specific. So some health systems may say the patients to be eligible for this have to be in this mini mental state exam range, this MoCA range, etc. ApoE4 testing, again, depends on where you are. In some settings, homozygotes are precluded from being treated. So ApoE4 testing is very important. There are MRI exclusions. If you have too many cerebral microbleeds at the outset, before treatment, you might be excluded from the study. There are also considerations of vascular disease, etc. You also have to be certain that there is a care partner. So you need somebody who can keep an eye on the patient for the development of side effects. And then we like people to be generally healthy. No serious psychiatric or immunological diseases active at the time of treatment because you're giving a monoclonal antibody. Outside the funnel, then there are still other considerations. Comorbid vascular disease or synuclein. Is Alzheimer's disease the only pathology in this patient, or is something else contributing as well? May not preclude them, but probably needs to be considered. What about issues about low or high BMI? Again, most of the people in the trials are in the mid-range of BMI. What about age? Now, age is not specifically excluded. There are age ranges for both of the clinical trials, but when a person gets older, you can define what that is for yourself. You have to talk about, is meaningful slowing of the disease going to be appreciated by this person in his or her lifetime? And as I mentioned, multiple copathologies can cloud the picture as well. So, biomarker evidence. How do we verify that a person is amyloid positive? Well, you could do an amyloid PET scan, and these are reimbursed. There are several FDA-approved tracers now that can give you that information. You can also do a CSF, a spinal tap, to assess the A-beta-42, p-tau-181 in the spinal fluid. I'm not sure I would go only on a low A-beta-42 in the spinal fluid. I would prefer looking at a ratio, A-beta-42 to 40, or a p-tau-181 to A-beta-42 ratio. Those are two of the primary measures in CSF that would validate that, in fact, the person has amyloid present. Now, the newest kid on the block are blood-based biomarkers. So there are a variety of measures out there. One of them is the high p-tau 217 to A-beta 42 that has been recently approved by the FDA and can be used for consideration. I think you, as clinicians, will have to decide, would I be comfortable treating somebody with these therapies only based on a blood-based biomarker? That's a decision I think that is looming out there, and some people say yes, some people say no. Let me turn it back to Ollie.
Thanks, Ron. Yeah, so Ron summarized things quite well. Again, this is a slide that summarizes the different suggestions for appropriate use recommendations. And full disclosure, Ron and I are part of this academic independent group that has really tried to take what has been in the clinical trials and translate it into clinical care, given that we're all developing proficiency and the systems are catching up. And we really erred on the side of caution and where we could really look at evidence and say something's been proven or hasn't. So the major considerations are, if you're considering it, the appropriate recommendations tell you a lot more detail than the prescription information, what things you may want to consider. So the clinical stage, they have to be the MCI mild dementia stage. Some recommendations, there's some thoughts about MMSE ranges. Of course, biomarker testing to make sure that if we're going to give a amyloid plaque lowering agent, that they actually have the AD substrate. And I think both the prescription information and the AUR really suggest that genetic testing is not important for diagnosis of AD, but it's a factor that tells us about risk. And so that should be done. And I think that's a really, really important aspect of this, because the risk benefit calculus cannot be really individualized as much unless we know the ApoE4 status. Of course, that has implications for the family also. And then there's all these other things that required also physician judgment, as Ron mentioned. What are things on the edges, for example, age, other medications? And I think a big part of it is also that it has to be patient-centered. And the patient and a care partner together have to commit to this therapy and have the knowledge and an appreciation that for them, the efficacy and risk profile and the burden may be worth it. This is not everyone's cup of tea. But for some people, it's really something that they will want to do if they qualify. All right. So for appropriate use recommendations, there are some aspects that Ron touched on. The MRI, for example, the appropriate use recommendations go along with what was done in the phase 3 clinical trials. And they say a baseline MRI should be done within 12 months, preferably within 3 to 4 months, actually, because microhemorrhages and superficial siderosis can actually evolve. And based on that and the number of microhemorrhages and superficial siderosis, and if there are indications regarding prior strokes, then some people may not be eligible. Those numbers were drawn simply because of the evidence base. In the future, as we know more, and potentially in other studies they get expanded, who's to say whether 5 for a person is okay, and what risk 5 microhemorrhages, what risk that imparts versus 3, for example. And then there are other things like histories of stroke or comorbidities and things like medications like anticoagulants and thrombolytics that at this point the appropriate use recommendations suggest that people not be considered. And particularly the evidence for anticoagulants is equivocal. And until there's a fuller base, the AUR suggests not considering people on anticoagulants. But thrombolytics are particularly a concern because occasionally people can present with ARIA symptoms, and people can think that this is a stroke going on. And there have been cases of bad outcomes where people have been given thrombolytics. So that's a major area of concern and development for safety. All right, so we're going to talk about a couple of quick cases here. Ron?
Sure. Let's take a look at a 72-year-old woman, mild cognitive impairment, usually of the amnestic variety. She's still driving. She's paying her bills, doing her taxes, really looks pretty functional, but she knows that her memory is not what it used to be and not what it ought to be. Family corroborates that. The clinician thinks, "Hey, this looks like mild cognitive impairment to me." Then we do the AD biomarkers and they're positive. So it could be a PET scan, could be a CSF, and she's an ApoE3/4. Generally healthy, but I think we would consider her for therapy for this particular indication. We'd counsel her that having an E4 allele puts her at a slightly higher risk of having some of the side effects that Ali talked about. But generally speaking, this would be a good candidate for treatment.
And so implicit in what Ron just spoke about was that the MRI looked okay. So the MRI for case one looked fine. So how about case two? We have somebody here who's also in the MCI, cognitive functional state, and has the AD biomarker positivity, is E3, E4 positive, but the baseline MRI shows 5 microbleeds. And really, again, this is an area where our evidence base will develop in the future, but strictly according to appropriate use recommendations, this would be somebody that at this point I would have a discussion with and say, maybe there are other options for you, maybe clinical trials or other things. And perhaps we'll have other studies for a person like this, but I wouldn't include a person like this. Would you, Ron, at this point?
No, probably not. But one qualification here is that the microbleeds, if the seen on like a GRE sequence, which is what was required for most of the trials, that may be too many. But SWI sequences sometimes are more sensitive and will pick up microbleeds. And to be honest, we're a little less certain as to what the cutoffs might be there. But to be conservative, again, staying with the 4 cutoff is probably a good idea.
All right. So, very quickly, we're going to go through some suggestions here about really communicating with patients and families in a patient centered way, because this is a therapy that requires a lot of commitment from the clinician, from a clinician team, from the health system, coordination, also patients and families. For reference, Vence et al., this is a Alzheimer's Association work group that Ron and I participated in that gives you really nice information. It's free. You can download it. It gives you really nice, straightforward language about talking to patients and families in a honest, straightforward way, discussing the basis of these medications, that why we think they may be disease modifying because they're removing amyloid from the brain, what benefits may they provide for patient groups, that it's not a good fit for everybody, what are the requirements for that. And it really requires a ongoing dialogue that oftentimes I don't find can be done necessarily in one sitting. And basically, this paper really talks to you about even scripts about how to discuss these things. For example, efficacy. No one comes in and says, gosh, I really want to change zero point 0.5 on my CDR over 18 months. Nobody understands that. So we have to translate that in something that resonates with the person. So, for example, if it's 30% slowing or so, it's an average of about 5 to 7 months of slowing compared to what somebody who was taking placebo would be. So contextualizing in that way, explaining, for example, that the data that Ron showed about going to the next stage of dementia for somebody who's in the MCI stage who is essentially independent, they have with these drugs on average a 30 to 35% less chance, even in that 18 months, to progress to a mild dementia stage where they become dependent on some activity daily living. That's face valid and meaningful for many people. Using honest and accurate language, not giving false hope, and discussing that these are not cures and that the benefits that you see are at a group level. So anyone's benefit or risk really can vary. The other parts that are really important are to really discuss the safety considerations, including the requirements of the monitoring of ARIA with the MRIs, the important communication of symptoms, and trying to contextualize it as much as possible to the individual patient. The requirements, again, including burdens of coming for infusions and also coverage. So while Medicare pays for this, there may be other costs with Medicare Advantage and also some copays, and also private insurance may require other things. And then really using all this to discuss also the reason for doing the ApoE4 testing and what it means and providing the right counseling for them is also really, really important. All right, back to Ron.
Sure. So, where are we going then with follow up and monitoring? Again, any of these ARIA signals presenting themselves may alter our therapy. So, what do we do if we run into some ARIA and we see that the person perhaps is symptomatic or not symptomatic? You'll do an MRI, determine is it edema, is it hemorrhage, and then depending on that particular array, you make some decisions. So, if it's mild ARIA E or asymptomatic ARIA H, you can continue treatment, but follow them monthly with MRIs until the ARIA resolves. But if the ARIA E, ARIA H is more than mild or the person is symptomatic, then you suspend therapy and monitor the person over time to decide whether or not you're going to reinitiate therapy. You want the ARIA E to resolve you'd like the ARIA-H to remain stable before considering. But this is an individual decision made with the clinician and the patient involved. So let's wrap up then by saying, here's where we are. The treatment goals, again, are to preserve cognition. We have to be certain we're not talking about stopping the disease. We're not talking about making anybody better, but we hope to slow down the rate of progression. But that could be important for certain people. These drugs do what they're supposed to do largely, clear amyloid plaques. That's maybe one component of this particular patient's total picture. Nevertheless, it could be important, but it has to be interpreted in the context of the adverse effects that we've been discussing, infusion reactions, ARIA, and the like. So it really comes down to the shared decision making that Ali was talking about. Often we'll come up with a clinical decision. Some of the more interesting questions that we have when we have our consensus conference on a weekly basis is, one, is the patient eligible by the inclusion criteria? But then asking the question, do we think that amyloid is the primary or major component in this person's clinical picture? Then we relay that information back to the patient and family and say, where do you want to go with this? We have some concerns. We think you might respond, but there might be some challenges because of other conditions. Where do you want to go? And let the patient and family decide as to how aggressive they want to be, or if they want to sit back and watch the process. Some will say, if we can treat one component of this process, I want to go. Others are saying, well, if it's only partially an answer and there are some side effects, I think I'll hold back. And then the follow-up, it is rather intensive, but I think it's important for safety purposes. But thus far, I think it's turned out pretty well. We appreciate your tuning in for this. Thanks again for joining us.